Hello and welcome to first of the cases of live surgical cases we just completed back in May 11th of 2024 at the West Coast Study Club. Cheers to all of our members who did the wonderful surgery. This is actually a wine that Dimple loves, so I'm hooked onto this conundrum. So thanks to Dimple for that. This is a case that we actually did a review as a group of the actual case workup. This is a case done by Dr. Gianmarco O'Brien, our co-director, prosthodontist in-house. This is a case where we did sinus graft and simultaneous placement of 3 implants in the upper right quadrant, namely the 2 molars and the bicuspid area, which was done particularly well. If you recall in the last video, we talked extensively about the actual treatment planning and case planning in terms of surgical process. We did the data collection from the various CBCT, intraoral scan, and in this case, Dr. O'Brien chose to do a stone model, which is perfectly fine. And then we did the restorative forecast, where the teeth are going to be in the conventional way. And for this particular case, Dr. O'Brien did make a conventional resin guide, and that was utilized in the actual procedure. But nonetheless, we did a digital planning, and this is a quick video that you may have remembered. This was done in Blue Sky Bio, a free software that you can download. Anybody can use that. And based on this, we found out where the positions were going to be. On this image, you can actually see the surgical guide made out of resin that's in place that tells us a reference point as to the particular relationship of the adjacent teeth. And here you can see the radiographic marking, including the long axis represented by the white gutta-percha. So again, if you recall, the flap design was talked about. I'm going to go through this very quickly. We prefer the lingualized incision design, and of course, the lingualized incision design is preferred to be placed right about the most palatal aspect of the future implant. So that's the red line that represents it. And then we have to decide, is it going to be remote, by definition, 1 tooth away, or localized incision? The next question, do we do papilla sparing or sulcular? Papilla sparing will look something like this, where the vertical release is slightly away from the adjacent tooth, preserving the interdental papilla, technically the coal. And the reason for doing that is to preserve the blood supply and the relative health of the tissue that remains onto the soft tissue, that remains onto the periodontal ligament and periosteum, of course. And then the sulcular design is to place the incision into the intrasulcular space, and therefore periodontal ligament is somewhat destroyed, but in healthy individuals, the healing potential is quite good. Here is the proposed access for the sinus window. It's more of a teardrop shape, a little narrower towards the front and flatter towards the back as we have planned. And in order to accommodate that, we had to debate which one is it of these 3 vertical release incisions that we can utilize, A, B, or C. B is obviously ruled out because it's in the mid-facial, the most vulnerable thin bone / gingiva, so we throw that out. And whether we choose A or C really depends on what kind of an access and what kind of closure we anticipate. We've talked about the hockey stick nature that is required as the initial incision comes off the gingival margin at more or less 90 degrees to the fringe-gingival margin, but it has to end up where we need it for many reasons, and because of that, the characteristic hockey stick curvature is seen in most of these. And in this particular case, we needed to do some sort of a deep release incision to make the flap go posteriorly to get the good access, which would end up something like this, and the closure was going to be fairly easy. And of course, the real reason why we're doing a flap is to try to get nice closure, good blood supply, and the desired effect of distribution of tissue type, namely mucosal tissue versus keratinized tissue, and the thick versus the thin tissue. So we then have to ponder one stage or two stages. How are we going to close this? And of course, simultaneous or staged really depends on the bone quality, how stable the implant can be placed initially in terms of insertion torque, and so forth. Once we reviewed the actual stone model and looked at the relative depression or lack of buccal tissue of volume on the distal aspect of the first bicuspid, we decided A wasn't going to work, so we actually had to resort to C. It was a remote incision, one tooth away, but it was needed to avoid the area that we have to expose that will have some form of low bone volume, therefore defect sitting immediately underneath. So here is the initial incision design. Note that at the mesial corner, mesial line angle, which were slightly off center, we do want that to be characteristic 90-degree. Picture a sun ray appearance. So if the tooth at the gingival margin sinus was a sun, then the rays go straight outwards. But it only goes so much before it starts to curve straight upwards in this image, and which is going to go superiorly and ultimately posteriorly. Very easy, simple exercise, but let's break this down. I am particular about how soft tissue incisions should be precise, clean, and crisp. After having trained so many clinicians doing this type of exercise, I realized that many people pay not much attention to this, and as a result, we end up with a lot of soft tissue deformation, gingival recession, and a lot of not so clean healing can be evident from this very exercise. Notice on the left of the screen, I have the blade pointed, the sharp side pointed away from the tooth. That's actually how I start. In other words, I like to get the very sharp point of this 15C blade to touch the crestal bone and then feel it, because I really don't know where it is. And then once I go through that, then I turn the blade completely 180. So now the sharp end of the blade end is pointing towards the bone and go straight down. So I do that in 2 steps. I feel that that's a safeguard, and that's the way we can actually do things much more predictably. The next is, how do we get into that posterior aspect? There isn't much choice but to use a sickle-shaped blade such as this. They do come as designated as 12B or sometimes 12D, depending on what brand it is. So it's a little confusing, but they're pretty much the same. They have the cutting edge both in the front and back of the sickle shape of the blade. Therefore, it can be used pushing or pulling action. It is a very dangerous instrument if you're not very careful. You could easily cut tongue, lips, and other places, hopefully not just fingertip. So do take extra precaution when this is going in and out of the mouth and moving around the natural teeth. Another alternative is to use what's known as the O'Brien knife, something very familiar in a typical periodontist hand, but not very much utilized outside the periodontal scope. It is a 90-degree offset blade. It is a knife meaning you need to sharpen it. So it is an instrument that you purchase as is, but as you use it over and over, of course, the blade has to be sharpened, just like a sharp curette with a sharpening stone. And this is something that once you get accustomed to, it is a very handy and useful instrument for most clinicians. So with the help of those small techniques and the appropriate armamentarium, we're able to raise a flap that's very predictable, very clean, without any jagged or unnecessarily roughened edges, which always will delay the healing and, of course, not get the best clinical outcome that we are looking for. Once we have the right exposure, we're starting to do the window preparation. And in this case, as you can clearly see, the window has been made with piezoelectric saw tips. There are a number of tips available. The one that you see on the top and to the right, the silver one, are the ones that have typical blades facing straight on the end of the shaft. Professor Son, my good friend, has actually designed them so that they're all over on the front and the back and the long axis of the blade, which is very handy. The Son's saw tip, the one that you see in the middle towards the bottom with the pear-shaped edges, which is also very handy because you can utilize front, back, and the sides. And this particular configuration is available from Medtronic's, the original piezoelectric surgery people. I tend to use a variety. I like my friend Son's tip quite a bit. So this is a technique that was introduced to the dental literature by Professor Son and his group from Daegu, Korea. And the idea is a replaceable. So you deliberately put bevels, 45-degree bevels onto the edges. Therefore, the window, when it's replaced back to the original position, does not sink in, which is a very nice, handy way to do things. So here we are now that the window was lifted. You can clearly see the outline. And this photograph particularly shows a good use of the Minnesota retractor. I usually put a little bit of sharp creases on the tip of the Minnesota so that this ascending zygomatic buttress is very slippery and not that easy to handle. So having some sharp edges at the tip of the Minnesota is not a bad tip. You see what I did there? Tip on the tip. Okay. All right. And then a series of curettes are going to be used to separate the membrane off the floor of the sinus, as well as the anterior border and the medial or the most midline area. And I'm not going to spend a whole lot of time. All you need to know is that you pick the right instrument that works in your hand, has the right configurations, and of course, the key principle is to stay on the bone. Therefore, you do not tear the membrane unnecessarily. In case you tear the membrane, I don't think it's a huge deal. My good friend Eric Park and I have written an article in 2023 on strategies of how to manage. Please look that up. It's a very fine manuscript that describes all the different scenarios and the techniques used to overcome that complication if you ever would arise. There's a little incident that we had when we actually pulled this window off. It didn't quite come off easily. It actually broke. It was quite thick, and it actually snapped in the middle, which tends to happen a lot. So by the time we furthered instrumented with the piezoelectric surgery device, the saw tip, and then ultimately got to the back, we got better, but there's still a little bit of that sharp edge remaining. There are a number of different instruments. We can use different cutting instruments, or to me a rongeur, bone rongeur, or a finishing off the edges, using direct vision using the piezoelectric surgery tip works quite well. And of course, after working on the curette, with the curette on the floor of the sinus and separating the membrane, this is the end result that we're looking for: complete separation, detachment, and passive sort of lifting of the sinus away from the floor, away from the lateral wall, superiorly, and into the medial surface of the sinus cavity. Here we see some images of the concentrated growth factors before it's pressed. That is lightly packed so that it has direct contact towards the Schneiderian membrane, which is truly where the osteogenic potential comes from. Not necessarily the bone, it's actually the blood supply, and the progenitor cells will come into the sinus cavity, into the future bone site through the Schneiderian membrane. So it's sensible to have the growth factors directly contact that area so we can start that progenitor cells to migrate into the area much more efficiently. And of course, this is a slimy material, so as soon as you put that into the sinus cavity, it will move around. If there is a tear of some sort, that will tend to disappear and possibly end up on the other side of the sinus through the tear. So we do have to be quite careful at this point. This is the sticky bone that's in preparation, And the sticky bone, of course, is clumped together, make sure it's well set, and I'm separating it into little pieces so that we can pack, and we use a standard amalgam pack-alike configuration instrument to pack. You just need to have the right depth and the width and the length so that you can push the bone into the exactly desired position so you don't underpack or you have voids within the sinus. And the last thing you want is a synovial membrane to have another sort of an indentation somewhere that's not visible. So it's very prudent that we pack this evenly into all directions, keeping this three-dimensional shape in mind. Once we have, say, 80-90% of the bone in the right position that you feel confident, you simply start the osteotomy process and place the implant as if this is normal healed site. In this program, of course, this is sponsored by Megagen, a very generous sponsor of the West Coast Study Club. So this is implant system from Megagen, their flagship line called the AnyRidge line. You put these in any type of ridge. As you can see here, there are different configurations for dense bone versus not. So it has a lot of nice features that will give you the primary stability we're looking for, especially in a case like this, where our desire is to do a one-stage surgical protocol. And this type of aggressive knife threads and very small crystal module that can be placed deep does allow that kind of configuration. So as you can see here, the implants, all three of these implants were placed deep relative to the crestal bone, and the crestal bone in an edentulous heel site is never flat. In fact, as you can see here, quite commonly the facial aspect has a slant because of more resorption as opposed to the palatal, which is thicker and more taller. So what do we do with these uneven surfaces? And here Dr. O'Brien is actually using a freehand technique, coarse diamond surgical burr with copious irrigation to shape the bone, and in order to not inadvertently touch the implant connection surface, he's placed cover screws in there to protect that. Now, of course, after making Dr. O'Brien try with sweats pouring out, we said enough of this tribulation, let's actually use an easier technique. And there is such an easy technique, and it's called the bone profiler system. This is a schematic of how this can be used. On the far left, you can see that gold structure, which is kind of like a small abutment with smooth surfaces with absolute parallel sort of a configuration, cylindrical, and the corresponding drill that has the right profiling angle is then used to line up with that cylindrical portion so that it doesn't move around. And when you rotate the drill, of course, the bone will be profiled at that exact predetermined angle and gap. And therefore, the healing abutment of the right size configuration can be placed, and the surgery can move on in a very expected, predictable way. So here's the actual kit in view, and now we have those cylinders in place, and with the rotary instrument, the cutting instrument in action, you can see the actual neat profiling. The profiling not only has to give you enough space for the healing abutment to sit, you actually need to have more space than the healing abutment. Let me elaborate. This is the most distal implant, the most posterior one, which is placed quite deep. And of course, profiling was essential. So the profiling of this nature can be done precisely using this device rather than with the freehand. It is possible, but it's a little bit hair-raising when you get a burr fairly close to the implant platform, and that's never a comfortable thing. So now, after the profiling, we are truly able to place the healing abutments exactly as we prescribe. And when we look at the higher power view, you might note roughly about 1 millimeter or so of circumferential sort of a bony defect. If this was classical periodontal disease, you might call that a moat defect or circumferential defect. This is not a defect because this is actually the biological space that is necessary. If, hypothetically, the healing abutment was touching the bone, we have several unwanted consequences. Number one, the healing abutment may not engage fully because that piece of the bone might be resisting. Therefore, after a few days, few weeks of healing, and as the bone remodels, the healing abutment all of a sudden becomes loose, and that's just an embarrassment and a practice management situation where patients start to think, what kind of job did he do? He do, she do. Was the implant even placed properly? So the last thing you want is a patient walking into your practice with a healing abutment in their hand. So profiling does solve that issue. You can tightly engage the healing abutment in the desired position. But more so than that, from a biological point of view, if you assume that bone was in direct contact with the healing abutment, of course, the healing abutment is not going to be part of the osseo-integrated implant system. It's only going to stay there for a short while, and then soft tissue has to form its biological complex. Soft tissue cannot form directly in between the bone and the healing abutment, so therefore the body will provoke a low-grade inflammation. In other words, a remodeling, and the body will try to get rid of the bone by active phagocytosis and osteoclastic activities, in which case the bone shape will end up being random as if it's an ongoing periodontal disease. Therefore, profiling it precisely, leaving roughly a millimeter gap, does give the epithelium to migrate into the area and form a new layer of periosteum, which also is going to be part of the sealing mechanism for the future permanent abutment. So this is prudent. This is very important to look at this image and create that uniform thickness of space around the bone to the healing abutment interface. Of course, at this point, the implants are fully seated, and we did achieve very good stability, so we felt comfortable placing the healing abutments. And just very quickly, the selection of the healing abutment. There are two things to consider, mainly the height and the circumference, or the diameter. Now, in this case, in the bicuspid area, it was straightforward. There wasn't a whole lot of profiling. We wanted as much soft tissue to move into the area. Therefore, a narrow and tall one was the ideal. In the molar areas, the wider the platform that we choose, the wider the keratinized zone we create by displacing the flap edge more to the facial, which is to our advantage. But the more bigger it gets, the more of a secondary intention healing we create. So it's got to be in moderation. So this one is about a 5 millimeter diameter, which is just appropriate. The second thing is the height. You can clearly see the height of the bicuspid is much taller than the gingival margin, and the ones on the molars are slightly higher. The higher, the easier to get the good primary closure with suturing around it, but the higher the healing abutment, the higher the risk of the patient inadvertently chewing and causing micromotion, and therefore a disintegration of the implant. So that's where we have to stand, a good balance of those factors. This is the final view before we laid the replaceable bone window back, and it fits like a glove. It fits perfectly, which is very well executed. And then you realize that large void on the second bicuspid first molar area, the atrophy, possibly due to the disuse or possibly due to some traumatic extraction in the past. Basically, that area we decided to patch and grow some bone because it's a deep void valley. There's a very good potential for the bone to grow, so we threw some extra sticky bone into that area, and of course the bone surface of the ridge was prepared in order to receive that. And then the next fun part is this poncho process. We did place some concentrated growth factors not pressed into the sinus cavity, but here is one that is pressed and made flat, and then we're creating a number of holes, in fact 3 holes on this stretched out CGF, because we are creating a poncho, just like this Mexican gentleman in this picture. Poncho where the head pokes through, but the rest of the body stays underneath. And of course, the rationale for this is to try to give as much growth factor and healing potential at the flap edge, which is the most vulnerable of the whole system in the initial days of healing. Remember the flap design? We left that papilla shape between the canine and the bicuspid, and that portion was never raised. So that's firmly attached healthy tissue. And notice how that good amount of volume does help, because when a suture punctures right through, we do want considerable amount of stable, lean meat, so to speak, to get good anchorage. So this is a good example of a nice flap design that works to our advantage. And now the suturing is well on its way. You can see the vertical closure is pretty decent. And as we get back, we kind of ponder, should we change the healing abutment to something a little bit taller, which would make things easy? But in this situation, we decided to make this a learning experience of suturing technique. So the suture, depending on how the bite and how much tension, the direction, the position of the bite, all of these will determine whether the flap edges will rise on top of the healing abutment or sit on the side, which is the preferred way. So let me quickly describe what I have coined the turtleneck suture technique. We've been talking about this for quite some time. I will have a separate video on this made available to our members. But at this point, I just want you to understand the sutures need to take small bite from the edge, no more than, in this case, you can see maybe 1.5 millimeters, but no more from the edge of the flap. And then the other characteristic is that the position of the suture bite has to be narrower or inside the diameter of the healing abutment. If not, we get in trouble. So it's very hard to see this in a three-dimensional way, but basically I will have some graphics to describe this in just a minute. So here we are, we made a good attempt, and the tissue seems to be sitting on the facial surface, and a couple more sutures were put into effort to pull that down, and eventually when we corrected everything, we got this turtleneck effect. So here's a nice model where the narrow neck, where the jumper, the turtleneck, simply goes over the head, and then because of the elasticity, it sort of tightly wraps around the neck. That's exactly what we want, except in the natural flap design, flap issue, we don't have that sort of elasticity where it does it automatically like in a real turtleneck. So we have to create that with the suturing technique. So this is how it goes. This is looking at it from an aerial view, looking straight down onto the two sides of the flap, and then the healing abutment in the center. We first draw this imaginary line right at the tangent of the edges of the healing abutment. Where the suture should be is critical. So here's an example where the suture started outside the healing abutment, taking a bite from one side, going to the opposite side, coming through, and is tied. As this knot is tightened, tissue will pull towards each other, and the tissue will most likely rise and go on top of the healing abutment. Whereas if you go into the inside of the imaginary line, in other words, where the suture stays within the diameter of the healing abutment, not outside, then what happens is as the suture is put through, the suture actually lies on the lateral aspect of the healing abutment. As you pull, most healing abutments have slight taper. It usually is parallel on the top, but there is a taper portion in some of them. Therefore, we utilize that and pull that towards the bone and not to rise. So again, the key is to have the suture introduced within the diameter, and that's how we get this turtleneck suture effect. Again, I have a very detailed video on this technique with good examples on another site. So there's the turtleneck suture. So this is a gentleman, Dr. O'Brien, our co-director of our study club, and this was when he and I went down to San Diego together for the Winter Symposium in the beginning of 2024. So let's look at how the case turned out. This is a view from the lateral surface. The implant line, alignment seems quite adequate, quite nice. The PA radiograph shows that they're not perfectly parallel from this angle, but oh boy, this is as good as we can get. So let's start looking at them in a profile view. In the cross-sectional view, in the first one, the most anterior, the second bicuspid area, you can see the implant is in good position. This did not go into the sinus cavity. The one in the middle is truly where the sinus lift has happened, and you can see that mound of new bone with the new floor of the sinus being represented on that cross-sectional view. And of course, on the posterior, the most distal implant, we see exactly that. What I see is that the bone is packed tightly, so there's no voids, and somewhere there is a cross-section of the replaceable bone window that can be viewed in a high-power magnification. So using this feature on the Vatek software, we are able to do slices at different areas from the three-dimensional renditioning, and we can see some very nice images that correlate. This is the first bicuspid, where we actually did second bicuspid rather, or the first implant in the front. We can actually see the facial bone contour of the newly grafted sticky bone. This is the middle implant with a good rise in the on the apical end of the implant, representing a good 4 or 5 millimeters of bone beyond the apex, which is adequate and very, very promising. Somewhere there you can kind of make out the replaceable bone window, not very clearly, and this is, of course, the most posterior one. Implant is well centered, and the bone seems to be very smooth outline, consistent, and very, very well bound. So thank you for watching this video. There's more to come in, let's say, another 6 months or so. Once the case is restored by this talented Dr. O'Brien, we will actually pre-create a third video on this case series that will show you how the case actually ended up. So thank you for watching, and this is a picture of Dr. Gianmarco O'Brien and his lovely wife Jamie at our last Christmas dinner. So you know, let's keep implants going, and I guess I'm gonna have to retire now that this prosthodontist is taking over the sinus. Time for me to disappear into the horizons. Thank you all, and have a wonderful rest of the day.